So with polycythemia vera therapy and myelofibrosis therapy, for a long time things didn't really change, and I think that one of the nice things that's going on now is that we're really starting to see a shift in that landscape. With polycythemia vera for a long time, we've had hydroxyurea and interferon, and we had ruxolitinib that obviously got approved, in the mid 2010s, and that changed therapy in the second line setting. But now with the emergence of ropeg interferon, which just got approved last year, we're really trying to figure out who are the optimal candidates for different therapies in different aspects of the disease. And I think that's something that's really an ever-evolving process. And so just with those, I guess, three therapies, right, ropeg just being a kind of newer interferon formulation, we're understanding kind of that there's different times to leverage those drugs. Potentially ropeg has this disease modifying effect, able to reduce JAK2 allele fractions, certainly something we want to consider in relatively low symptom burden patients that have maybe are younger and where we can get the most bang for our buck using that. On the other hand, you have ruxolitinib, which is very good for symptoms, splenomegaly and the rare patients that have that, and certainly something you want to leverage for patients that are really suffering from the disease from a symptom side of things, because really we can rapidly improve those symptoms with JAK inhibition. I think something that's emerging is obviously where we're going to leverage some of these novel agents that are under investigation right now. So we have Rusfertide, which is a hepcidin mimetic, which has shown great effect in the phase 2 studies of being able to reduce phlebotomy requirements in patients that are heavily phlebotomy dependent. And that's something that we're going to have to come to terms with as far as where does that fit into this armamentarium? Is this something we're going to leverage early on in the disease? Is it just going to be for high phlebotomy requiring patients? Do we have to get rid of phlebotomies altogether and use something that's a little bit more rational that doesn't allow patients to become iron deficient and come with all the symptoms there? And so this is something that we're figuring out. I think there's some provocative abstracts this year at ASH looking at variant allele fraction reductions with ruxolitinib. So obviously I talked about the fact that we've been using ropeg for the benefit of VAF reductions, but now we have data that maybe ruxolitinib is able to do that too. And so does that shift things? Like, should we be using ruxolitinib maybe earlier on to induce those potential, change in disease modification? I think we'll have to figure that out.